is presented in 13.2. Histamine, a major component of muscle granules, is a low molecular weight vasoactive amines. Its effects, which appear within 30 to 60 seconds after release, are dependent on activation of 4 different types of receptors found on cell in various types of tissues. Activation of H1 receptor results in concentration of smooth muscle in bronchioles, blood vessels, and the intestines, and generally induce pro-inflammatory activity. In addition, this is increased capillary permeability, altered cardiac contractility, and increased mucus gland secretion in the upper respiratory tract. Binding to H2 receptor increased gastric acid secretion, airway mucus production, and permeability of capillaries and venues. H3 receptors are found on central and peripheral neural tissues. Bone marrow cells, muscles, and peripheral blood cells such as eosinophil, neutrophil, and basophil all have H4 receptors. H4 receptors appears to be involved in immune regulation, including chemotaxis of muscles, recruitment of eosinophils, neutrophils, and basophils, and cytokine secretion. In the skin, histamine is responsible for local erythema or redness and wheal and flare formation. Contraction of the smooth muscle in the bronchioles may result in airflow obstruction. Increased vascular permeability may cause hypotension or shock, depending on the route by which an individual is exposed to the triggering allergen. One or more of these effects may be seen. Eosinophil chemotactic factor of anaphylaxis (CFA) is another performed factor released from granules. This attracts eosinophil to the area and induces expression of eosinophil receptor for C3b. Eosinophil have granules that contain major basic proteins, eosinophil cationic protein, eosinophil peroxidase, eosinophil-derived neurotoxins, histamines, and phospholipase D. All of these products are toxic to bronchial epithelial cells and to helminth parasites. Killing of parasites is thought to be the reason that IgE production evolved. One of the proteolytic enzyme released is tryptase. Tryptase cleaves kininogen to generate bradykinin, which induces prolonged smooth muscle contraction and increased vascular permeability and secretory activity. Complement splits products are also released when C3 is converted to C3a and C3b. Newly synthesized mediator, in addition to immediate release of preformed mediator, mast cells and basophils are triggered to synthesize certain other reactant from the breakdown of phospholipids in the cell membrane. These products are responsible for a late-phase allergic reaction seen within 6 to 8 hours after exposure to antigen. Newly formed mediator includes platelet activating factor or PAF, prostaglandin or D2, leukotrienes, LT, B4, CD4, C4, and D4 and E4, and cytokines. Prostaglandins and leukotrienes are derived from arachidonic acid, a membrane lipid binds to separate metabolic pathway. In one pathway, the enzyme 5-lipoxygenase cleaves arachidonic acid to generate leukotrienes. The other pathway uses cyclooxygenase, which result in prostaglandin production. PGD2 is the major product of the cyclooxygenase pathways. When released by mast cells, it mimics the effects of histamine, causing bronchial constriction and vasodilation. It is much more potent than histamine, but it is released in smaller quantities. In skin reaction, PGD2 triggers wheal and flare formation, thus the overall effect is to enhance and potentiate the action of histamine. Leukotrienes resulting from the 5-lipoxygenase pathway of arachidonic acid metabolism are also responsible for late-phase symptoms of immediate sensitivity. Leukotrienes CD4, D4, and E4 were originally collectively named the slow-reacting substance of anaphylaxis. LTC and LTD are 1,000 times more potent than histamine in causing increased vascular permeability, bronchoconstriction, and increased mucus secretion in small airways. In the intestine, leukotrienes induce smooth muscle construction. Systemically, they may produce hypotension as a result of diminished cardiac muscle contractility and lessened blood flow. LTB4 is a potent chemotactic factor for neutrophils and eosinophils. The appearance of eosinophils is especially important as a negative feedback control mechanism. Eosinophil release histaminase, which degrades histamine, and phospholipase D, which degrades PAF. Additionally, superoxidase created in both eosinophil and neutrophil cause the breakdown of leukotrienes. Eosinophil products can also have a damaging effects. Eosinophil cationic proteins and eosinophil-derived neurotoxin contributes to extensive tissue destruction. PAF is a phospholipid released by monocytes, macrophages, neutrophil, eosinophil, muscle, and basophil. The effects of PAF includes platelet aggregation, chemotaxis of eosinophil and neutrophil, increased vascular permeability, and contraction of smooth muscle in the lungs and intestines. Cytokines released from mast cells include interleukin 1, 3, 4, 5, 6, 9, 13, 14, 16, GM-CSF, and tumor necrosis factor alpha. These cytokines alter the local microenvironment, leading to an increase in inflammatory cells such as neutrophil, eosinophil, and macrophages. Interleukin 3 and 4 increase IgE production to further amplify the T helper cells 2 response. In addition, interleukin 3 is a growth factor for mast cells and basophils, and interleukin 4 recruits T cells, basophils, eosinophils, and monocytes. Interleukin 5 also recruits eosinophils. A high concentration of tumor necrosis factor alpha may contribute to the symptoms of shock seen in a systemic anaphylaxis. The newly formed mediator are responsible for a late phase reaction in 4 to 6 hours after exposure to the allergens during numerous cells such as eosinophil, neutrophil, T helper 2 cells, mast cells, basophils, and macrophages exit the circulation and infiltrate the allergen-filled tissue. They release further mediators that prolong the hyperactivity and may lead to tissue damage. Now let's talk about the clinical manifestation of immediate hypersensitivity. Type 1 hypersensitivity is a widespread health problem as it is estimated that up to 25% of the population suffers from some sort of allergy. The clinical manifestation caused by release of both performed and newly synthesized mediator from mast cells and basophils vary from a localized skin reaction to a systemic response known as anaphylaxis. Symptoms depend on such variables as route of exposure, dosage, and frequency of exposure. If an allergen is inhaled, it is most likely to cause respiratory symptoms such as asthma or rhinitis. Ingestion of an allergen may result in gastrointestinal symptoms, and injection into the bloodstream can trigger a systemic response. Anaphylaxis is the most severe type of allergic response because it is an acute reaction that simultaneously involves multiple organs. It may be fatal if not treated promptly. Coined by biologists Paul Jules Porcher and Charles Robert Richet in 1902, the term literally means without protection. Anaphylactic reactions are typically triggered by glycoprotein or large polypeptides. Smaller molecules such as penicillin are haptens that may become immunogenic by combining with host cells or proteins. Typical agents that induce anaphylaxis include venom from bees, wasps, and hornets, drugs such as penicillin, and foods such as shellfish, peanuts, or dairy product. Additionally, latex sensitivity is a significant cause of anaphylaxis among healthcare workers and in patients who have had multiple surgery procedure, such as children with spina bifida. It is estimated that approximately 10% of all healthcare workers have been sensitized to latex due to the implementation of OSHA regulation requiring gloves for laboratory procedures and for working with patients. Clinical signs of anaphylaxis begins within minutes after antigenic challenge and may include bronchospasm and laryngeal edema, vascular congestion, skin manifestations such as urticaria or hives, and angioedema, diarrhea or vomiting, and intracerebral shock because of the effects on blood vessel and smooth muscle of the circulatory system. The severity of the reaction depends on the number of previous exposure to the antigen with consequent buildup of IgE on muscles and basophils. Massive release of reactant, especially histamine, from the granules is responsible for the ensuing symptoms. Death may result from asphyxiation due to upper airway, edema and congestion, irreversible shock, or a combination of these symptoms. Rhinitis is the most common form of atopy or allergy. It affects about 15 to 20% of children in developed countries. Symptoms include paroxysmal sneezing, rhinorrhea or runny nose, nasal congestion and itching of the nose and eyes. Although the condition itself is merely annoying, complications such as sinusitis, otitis media, ear infection, eustachian tube dysfunction, and sleep disturbance may result. Pollen, mold, spores, animal dander, and particulate matter from house dust mites are examples of airborne foreign particles that act directly on the mast cells in the conjunctiva and respiratory mucous membrane to the trigger at rhinitis. Particles no larger than 2 to 4 micrometer in diameter, such as pollen, dust, or fumes, may reach the lower respiratory tract to cause asthma. Asthma is derived from the Greek word for fainting or breathlessness. It can be defined clinically as recurrent airflow obstruction that leads to intermittent sneezing, breathlessness, and occasionally a cough with sputum production. The airflow obstruction is due to bronchial smooth muscle construction, mucosal edema, and heavy mucus secretion. All of these changes leads to an increase in airway resistance, making it difficult for inspired air to leave the lungs. This trapped air creates the sense of breathlessness. Food allergies are another example of type 1 immediate hypersensitivity reaction. Some of the most common allergies involves cow milks, peanuts, and eggs. Symptoms limited to the gastrointestinal tract include cramping, vomiting, and diarrhea, while spread of antigen through the bloodstream may cause hives and angioedema on the skin, as well as